I'm Professor Baraka Bonyo. Currently, I'm a professor of medical physiology at Uzima Medical School. And I'm also a registrar at Kibaki University. I'm registrar in charge of research, innovation, and planning. My area of expertise, I'm a medical physiologist, and I've done a lot of work on lung, and specifically lung surfactant. I have also done a lot of work on, a bit of work on lung cancer, and I will not go into details about that. If we get a chance, I think Tunge will share my CV. I have a specific interest in lung inflammatory diseases, and when COVID came up, I thought I could lend my expertise in finding out alternative cure. And so I thought about the use of lung surfactant for treatment of COVID-induced acute respiratory distress syndrome. And later, I've seen a lot of my colleagues have jumped into it, and a lot of work is going on as we speak. But I want to introduce you to this topic in terms of what can we do with lung surfactant in terms of treatment of COVID-19. I will start by introducing the lung surfactant, because I would have started by talking about COVID-19, but I think how do I move to the next slide? Can somebody help me here on how to move to the next slide? Okay, yeah, okay. Okay, now let me first of all introduce lung surfactant, because I know most of the journalists are aware of coronavirus, but not lung surfactant. Lung surfactant is a soapy substance released by the lungs. It is a substance that enables your lungs to relax and contract easily. Without lung surfactant, your lungs will not easily contract and relax when you breathe in and out. And your lungs will develop what is called atelectasis, meaning it will be cracking, it will be dry and cracking. Lung surfactant was first discovered on newborn infants, or infants that are prematurely born. And they were found that they lacked surfactant and they were not able to survive because their lungs were collapsing. And therefore, later on, it was found that if they were given lung surfactant, they survived. And therefore, as we go along, I will talk more about it. But let me first of all start with corona. As you know, coronavirus belongs to a family of virus called Coronaviridae. They are enveloped viruses with just 65 to 125 nanometers. And they are very dangerous to humans because they cause a severe acute respiratory distress syndrome. I'm not going to go to the details of corona genome, but I will just explain that because of its structure, it quickly gets into the cell and get to the DNA of the human being and uses its RNA polymerase to replicate. That is the general structure of coronavirus. And I will not explain all the all the proteins involved, because I was told here we have journalists. So that is generally the structure. I want to get to the bottom line of this topic. Yeah. This topic is to emphasize that coronavirus affects the production of lung surfactant. And from the figure here, you can see that coronavirus attaches to the wall of the epithelial wall. The alveolar epithelium consists of two types of cells. It consists of alveolar type 1 cell and alveolar type 2 cells. And alveolar type 2 cells are the cells that are responsible for production of lung surfactant. Coronavirus attaches to the alveolar type 2 cells using two types of receptors, TMPRSS2 and ACE2, adenosine converting enzyme. I think you have heard a lot about this. And then it gets into the cell, hijacks the RNA replication system of the cell, and then processes itself and moves out of the cells through exocytosis. During this process, the coronavirus destroys the alveolar epithelium and destroys the alveolar type 2 cells that are responsible for production of surfactant, implying that at a certain stage of COVID infection, the alveolar epithelium is incapable of producing lung surfactant. As a result of this, what happens to the lungs is that you will find development of acute respiratory distress syndrome. And not only that, you will find that the lung will be injured. So you have acute lung injury, which is constituted of the following: diffuse alveolar damage, acute fibrosis, organizing pneumonia, and sepsis. And if you look at the details of this, you will find that because the epithelium is not now working, water gets into the lungs, and you will have even pulmonary edema and all that. Now, here is an indication of what happens. So this is an MRI for a normal person, but a person with COVID, there is intrusion or infiltration of water into the lungs. And if you look at the X-ray, you can see in a normal person, the X-ray is quite clear. The ribs are clear, you can see, and it is not translucent, it is dark. But if you move with the COVID infection, you will end up with pneumonia. Water will infiltrate the lungs, and therefore you can't breathe. And most of the people at this stage die. I would show you an example of a patient, or a 70-year-old patient that was admitted. On the first day, you can see how its lung looked like. On the third day, when he died, I don't know whether you can see that. Okay, let me move this down. When this person died, you can see that his lungs were infiltrated by water and all this, so he had pneumonia. Now, remember, at this point, it is not only the infiltration of the liquid or the pneumonia part of it. There's a lot going on here, including excessive inflammation. Now, if you look at the histology of a patient of COVID-19, again, you will see the same problem. This is a normal lung. In a normal lung, you will see a very thin membrane, and there is, as you can, where I'm pointing in, you will see that the lung, the alveolar is very clear. But with COVID-19, there is no longer, as you can see here, there is no longer alveolar membrane, and alveolar is infiltrated by cells. The epithelium is totally destroyed. The epithelium where we have the alveolar type 2 cells is totally destroyed. So at this point, alveolar type 2 cells is not functioning properly. It is not producing surfactant. And therefore, my proposal is that at this stage, lung surfactant is missing, and it is important that we consider introducing it at a certain point of COVID-19 infection. Now, that is not the only thing that COVID-19 does. What we have seen there is just an histology. We've just seen the structural destruction, but there's molecular destruction of the alveolar epithelium, including affecting endothelial cells, and with its effect on angiotensin converting enzyme, so many things happen, including non-production of what is called von Willebrand factor, which is important for coagulation of the blood, and therefore you will end up with thrombosis. And because also you are lacking angiotensin, there will be angiotensin 2, there will be vasoconstriction, fibrosis, and inflammation. I will bring in the part of inflammation in terms of surfactant. Now, let me introduce the surfactant again properly. I just talked about what it is, but I did not talk a lot about its chemistry, which is very important in its function. Surfactant is a phospholipid. A phospholipid meaning that there is a component which has a phosphate and there is a component which has a lipid. Okay, and we have several components of these lipids. We have phosphoglycerol, phosphocholine, etc., etc. So it's a combination of phospholipids. And what is important with these phospholipids, if I can move, oh sorry, before I go to the importance of the phospholipids, it's not only these phospholipids that are there. There are also surfactant proteins. So we have surfactant protein A, surfactant protein B, surfactant protein C, and surfactant protein D. Some of these surfactant proteins are anti-inflammatory. They are effective anti-inflammatory products. And what they do when there is a virus or when there is a bacteria that induces inflammation in the lungs, they opsonize them, meaning they cover it and they present it to macrophages. And therefore, macrophages are able to engulf the bacteria or the virus and destroy it. Okay, I've introduced that. I've already talked about this in terms of where the surfactant is being produced. It's produced by alveolar epithelial cells. So imagine what I had already talked about before, about the epithelium. The alveolar epithelial cells are found in this region, and COVID-19 destroys this region. And therefore, totally, we propose and we believe that in a COVID patient, there is reduced lung surfactant production. I will show evidence. There is a colleague who has done an experiment and found that the surfactant is deactivated in COVID-19 patients. So the synthesis of surfactant, I'll not go into details about it. It is synthesized in the lamellar body and exercised into the alveolar airspace. Now, I want to start now talking about why do I think that surfactant can be useful for treatment of COVID-19. As you can see here, surfactant is almost like a soap. It has an hydrophilic head and hydrophobic tail. Hydrophobic meaning it is not water-loving. Hydrophilic means it is water-loving. And this is the same way soap works. There's a component that loves water there's a component that does not love water. And so when there's that, the component that does not love water engulfs the gut, and it releases it out. So you are always advised to wash your hands thoroughly. The advice is that when you wash your hands, then you will wash out COVID virus. Now, this is one of also, if we use surfactant in the lungs, then the lungs, if we use it early during infection, then it is possible that it can actually form micelles of the virus and release it out instead of letting it get into the epithelium. So this component of surfactant is very important for this theory that it can reduce infectivity of the epithelial cells by the virus. Okay. Now, the following have been stated. One is that COVID replicates in the alveolar type 2 cells, and therefore that reduces the production of lung surfactant. Two, COVID-19 induces inflammation. And if it induces inflammation, then surfactant proteins can be useful. And this inflammation as well deactivates lung surfactant. So we hypothesize that surfactant replacement therapy could be a magic bullet for rescuing COVID-19 patients with terminal acute respiratory syndrome. Why do we think so? Number one, surfactant, when given to premature babies with infant respiratory distress syndrome, it increases the mortality by increasing the oxygen, what we call the VQ mismatch, which means it enables the patient to get more oxygen. So exogenous surfactant is very effective in infant children with RDS. So we believe if the same is given to COVID-19 patients, then it will increase their accessibility to oxygen and it will reduce mortality of the COVID-19 patient. In this experiment, you can see that the patient pressure of oxygen is increased with patients who have ARDS. And these are not COVID patients. There are patients that normally also can have ARDS without COVID. And there is an experiment that was done, and it showed that when you give these patients exogenous lung surfactant, then their patient pressure of oxygen increases. As you may realize, what kills a lot of people is that they don't get enough oxygen, and that's why they're normally given oxygen. But lung surfactant, when given to ARDS patients, increases the availability of oxygen to these patients. Again, that shows the same thing. There is also evidence that surfactant proteins, when given to people with ARDS, there is a level of improvement. So during acute lung infections, when patients are given surfactant protein A and surfactant protein D, that is included in the phospholipid, there is always reduction on inflammation. And that is because these proteins will opsonize the bacteria or the virus, or will react with other inflammatory products in the lungs, and therefore may increase the survival of COVID-19 patients. There are a few experiments that have been done, and there are fellows Simon et al. 2021. They have just tried a few patients. They gave 7 COVID-19 PCR positive ARDS patients. They gave them lung surfactant. And they showed that this reduced their problems with ventilation, and therefore they proposed that surfactant could be useful. But this is a small study. A bigger study needs to be done to show that surfactants are important. There is also another study by Peter Jobs, which also saw that patients that are given exogenous surfactant recover to some extent, and they give them surfactant plus steroids. As you realize today, when a patient is taken, a COVID patient is taken ill, they are given dexamethasone, which is a steroid, and this steroid is known to induce production of lung surfactant by enhancing proliferation of alveolar type 2 cells. There are so many studies. For example, there's a company which is called Wendy Therapeutics. They are already studying a specific type of surfactant called lusinactant on COVID-19 and ARDS patients. They are still waiting for the results and see what happens. So what am I proposing? First, I'm proposing that COVID-19 patients should continue being treated with steroids because those steroids enhance surfactant secretion. However, this treatment should be next. We should compare the treatment and surfactant production. So the patients that are undergoing steroid treatment, we should look at, is surfactant production increased? Are they recovering because of increased surfactant production? Number two, we are proposing that we determine which type of surfactant can be used for treatment of COVID-19. Because they are different, they're synthetic, they're natural surfactants, there are different types of surfactant combinations. So we are looking for opportunities or funds to test what type of surfactant is effective in the treatment of ARDS related to COVID-19. The other thing is that what should be determined is what is the timing of administration of this surfactant. So if you do the treatment late, can the patient recover? If you start it early, will the patient recover? Two, before I go there, before I finish, we should also determine the surfactant levels in patients with COVID-19. There is no study that has followed COVID patients from the point of infection to the point of death and looked at surfactant production. That will give us an idea of when we can begin the treatment with surfactant and when the treatment, even if it is given, it will not have an impact. So in the timing of administration of surfactant on COVID-19 patient should be determined. And with that, I would like to make the following conclusion: that assessment of lung surfactant levels in COVID-19 patients should be included in determination or evaluation of the level of sickness of a COVID-19 patient. 2, lung surfactant treatment should be considered with other interventions for treatment of COVID-19 induced ARDS. 3, that we need to determine the right combination of surfactant for treatment of ARDS. 3, we believe that, and we propose that a patient, when a patient comes in, there's a need to measure the surfactant level in these patients, so that maybe we can rescue them if we find that the surfactant levels are very low. And with that, ladies and gentlemen, I conclude my presentation.